We're going to have a session now looking to improve everyone's advocacy and understanding around the topic of patients' involvement in access decisions. So I'm delighted that we're joined by a number of speakers who are each going to give a short opening statement of different perspectives, including advocacy, healthcare professionals, payers and HTA bodies, and then a regulatory perspective. So we'll start that and then we're going to get into a panel discussion. So if you have any questions throughout, please post them in the chat and we'll hold all of the questions till after all of the presentations. So first off, I'm delighted to hand over to Giora Sharp, who is a patient advocate from one of the Israeli patient groups. Over to you, Giora.
Thank you very much, Zach. Thank you very much, Samantha, for the invitation. I'm really proud and happy to be here and see so many close friends in the audience. So hello to everybody. Can we go to the next slide? So when I talk about patient engagement in HTA, I always like to start with a quote. The quote is from Karen Facey, who was the president and CEO of a health technology assessment agency in Edinburgh. And she's also the president of the International Network of Agencies for HTA. And she's a very strong advocate for patient involvement in HTA. She was one of my teachers or instructors at the U-Party training, which I did a couple of years ago. And she wrote a book about patient involvement in HTA. And the book opens in a sentence, which I think, from my perspective, summarizes and says everything that every patient and every patient advocate needs to do. And it says that if you are not involving patients, you are not doing HTA. And I think that's basically is the whole essence of patients' involvement in HTA. And she continues in the opening of the book. It's that simple. Patients' involvement improves the quality, relevance, and value of HTA. It is difficult to conceive of HTA technology assessment being conducted in a meaningful way in the 21st century without the involvement of the patients. Next slide, please. So why should we involve patient perspective into HTA? Because usually decisions today should not be made only on the ground of clinical efficacy data that's like they are being done by the HTA bodies. Without the involvement of patient perspective, usually they look at the data coming out from a clinical trial and the data from the real world of the patients and the evidence that we are collecting from the patient is not reflected in the decision of the HTA bodies. So why should we include that? Because otherwise we don't have enough data about what is the influence on the side effect or the quality of life of the patients. How does the treatment influence the ability of the patient to work and to have a social activity? Or, for example, what is the influence on the family, on the caregivers, and the ability to plan pregnancy and expansion of the family? So I think the patient input is critical to better understand the value and the influence of the treatment of the patient's life. Next slide, please. So the value of patient perspective comes from patients and caregivers, those who are living with the illness. And there is a quote here, which I also like to always to mention. It comes from a paper which was written about the topic, that no one knows better what is it like to live with the illness day in, day out than those who are doing it, the patients and the family and friends who care for them. In addition, when we put the perspective of the patients into the whole process of HTA, actually what we are doing, we are giving qualitative context to the quantitative data. We are not just looking at the data, what was the percentage of progression-free survival, the improvement. We are giving a perspective of the qualitative context to that numbers. And I think another important thing, which is not less important, we are challenging the professional assumptions. Because I give just a small example. when I came to one of our leading doctors, asking him to collaborate with me, connecting me to patients to collect real-world evidence about a specific drug, he asked me, why do you need this perspective of the patients? We are sitting in the HTA committee and we are representing you, the patients, so there is not really need for you to do all this work. So I think that's just an example of the misunderstanding of what is the real perspective of the patient, why should be included. Next slide, please. So where are I standing in my country? I've been advocating for patient involvement for the last 3 years, I think, in my country after I finished the UPATI training. And it's been a challenge. I admit we are far away from the things that are being done in other countries. And when I talk to people who are involved in HA in my country, I usually hear quotes like, you, the patients, you cannot participate in the HTA process because you are not objective and you are representing only your very narrow own disease interests and not the interests of the whole patient. And also patient organizations are not independent as they are supported by pharma companies. As a patient advocate for 20 years, I can testify that this is absolutely wrong and not correct, but there is no question that it represents the need for a major change in the concept. I did manage to open some small door in the HTA body in our country. And actually from last year, patients can write a programmed letter submitted to the HTA committee and describe how the treatment is influencing. But that's still only the first step because there is no representation of patients in the committee. And also they don't even allow us to come and be testify in front of the committee like they are doing at EMA, at NICE and other committees. Okay, so I think next slides. There's a couple of slides. I'm not going to go into it because we have a representative for EMA, but this slide just shows how EMA has been increasing the patient involvement over the years. In 2008, there were 167 patient engagement up to 770 in 2016. And I'm sure this number has been increasing over the years after. And next slide, please. I think it's my last one. And this is another example how it has the evolution of the patient engagement at the FDA, which started in 1988 with the first HIV community and has been going and improving and increasing every year. And you can see some of the changes that the FDA has incorporated, which has made a huge change in the US in this respect in patient engagement. So I thank you very much for your listening.
Thank you very much, Giora. So next, I'm going to give a UK perspective around patient involvement in access decisions, because clearly there's huge differences happening between different countries. So firstly, kind of my view on why we need patient involvement in HTA. And I like to show this slide quite a lot because I think it makes it really obvious that if you look up from the left-hand image, when you're looking on as an external third-party perspective, you think you can see the outcomes that matter. You think you can see that things are working. But actually, if you look at the image on the right, from a patient perspective, and unless we look at things from a patient perspective, we can't get the true experiences and we can't understand whether actually the outcomes we're measuring matter. And the simple adjustments that we could make to improve things from a patient perspective aren't being measured, aren't being included. So one of the things that we hear from HTA agencies as to why they want to include the public and patients in their decisions are essentially twofold. The first one is around giving opportunities to be involved so that there's a feeling of involvement. Now, I have real problems with that. Yes, involvement is important, but sort of tick box involvement, just as you're part of the process, is not sufficient. And the second one's much more kind of quantifiable and useful around making sure the guidance given has greater focus and relevance and really affects the things that matter for patients and those affected. And that's where I think the focus should lie. Now, one of the problems we have with payers, with HTA and with regulators is a dichotomy between what they should be doing and what they may be doing. And I must say that the EMA in particular has taken much greater advances in this area in comparison to most of the national payers. So looking simply at the mission statements of what these organizations do, the EMA is obviously around making regulatory decisions as to what drugs are safe and effective, but they're very clear that they're for the benefit of patients. Now, when we look at it from a payer perspective, we see much kind of more debate as to whether they're for the public, or are they for patients, or are they for users of the NHS? And I think that's where a lot of the tension lies behind. If it's for the public, we want to look at what's good for the taxpayer, looking at the costs as a whole and looking at the opportunity cost of some of that. Whereas if we're doing it for patients, we're looking at what outcomes matter to patients. How is the improvements measured against the outcomes that matter for patients? So looking at from a UK specific perspective as to where the opportunities are for involvement, because we have 3 different processes for the different countries in the UK, and there are different opportunities for involvement in each. It's not to say that one or other of them is doing it necessarily better than each, but they're doing it very differently. So NICE is often recognised as a gold standard internationally in terms of involvement. And if you look at the slide, you can see that there's opportunities for involvement at every stage of the process. Now, SMC and AWMSG have taken it differently. Patient-focused meetings, so the most well-known is PACE, and we have a representative from the SMC here to talk to us about that, where the benefits of that are. But one of the problems I see around involvement is the question as to whether or not that's having impact on the decision, or whether, to the first slide, we're just having the opportunities to be involved, but not really influencing the decisions and getting the outcomes that matter. So what do other organisations think around it? NICE held a workshop at the beginning of last year with around 20 patient organisations, and the report from that said that these patient organisations do not feel that their efforts contribute to the process and that they're not seen as credible. Now, in many cases, I think that that is related, that because they're not seen as credible, they're not having opportunities to impact, but also the impact on decision making is not usually obvious, as Myeloma UK noted, because it's not being done necessarily in an evidence-based format. Where are the mechanisms to influence the decisions? So as persuasive sometimes as patient testimony can be, in processes like NICE, it's very hard to influence the decision. So if you look at the image on the right-hand side of the slide, NICE uses a system called QALYs, so it's quality adjusted life year gained. And what that means is measuring the gains in both survival, but also gains in quality of life. Now, clearly, as patient organisations, we're not going to influence the data around survival gains, but there is potential for patient organisations to be showing data around quality of life and where the gains are. And bringing it back to my first point, patients are the ones for whom the outcome matter. And we need to make sure that we're gathering important information as to how the quality of life of new treatments affects the lives of patients. So to use a kind of example as to why we need to do that, this was something that was posted on Twitter last week by one of the chairs of one of the NICE committees. Now, I'm sure it was meant as a flippant joke, but they were looking in a COVID perspective at the role of hand sanitizer. And the gel on the left kills 99.99% of germs, and the one on the right kills 99.9%. And the one on the left is cheaper. So from a pure survival / outcomes clinical perspective, the one on that one is clearly more effective and therefore dominant. But actually, I mean, would you say that 99.99 is really that much better than 99.9? Is that an outcome that actually matters to patients? Or would more important things be things like how long it's effective for, how often you have to wash your hands? If we're talking about immunocompromised patients, what impact does it have on your hands if you're washing your hands every 5 minutes? Is one of them more sensitive than another? Actually, these kind of outcomes are probably far more important than a pure, probably labeling difference between what percentage of germs are being killed. Now, I would say that there's different stakeholders have different responsibilities here. So clearly on the HTAs and on payers and agencies to change the processes to make sure that they're having a meaningful impact, but also on patient advocates in terms of, as organisations, we need to develop the capacity and the capability to be involved in these processes effectively when we get the chance to do so. I would say that that's through evidence-based advocacy, and there are many trainings going on from organisations throughout Europe, such as We Can, on how to generate evidence-based advocacy. But we also then need to put in the work and the resources to generate that evidence, and in a format that stakeholders can use for decision making. Now, this isn't something that we have to do on our own as organisations. This is things where we can come together and we can collaborate. But if we don't have that evidence, it's very hard for stakeholders to listen to patient input in a measurable and quantifiable way. But I also would say that responsibilities lie on other stakeholders, and particularly here on industry. The involvement of patients in HTA goes a long way beyond HTA. There are lots of opportunities to gather evidence as to the patient perspective in R&D, and the data gathered here really influences HTA decisions. We have a roadmap as to how to involve patients in the R&D process, but at the moment, in many cases, we're not doing this. And that then means when you're sitting at an HTA committee and trying to argue as to how the quality of life of patients is affected by this, in many cases, we don't have the data we need to be able to make those decisions. Thank you. So I'm going to hand over to Adele now to share her perspective as a healthcare professional who's been involved in many NICE appraisals over the last few years.
Okay, that's great. Thank you very much, Zach. So on this matter, I'm not an expert because obviously I'm not a patient and I haven't not had blood cancer. But I have been a clinician for 32 years, and 28 of those I've spent working with patients with blood cancer. And over the years, I've worked together with patients on numerous different projects. So in the simplest form, obviously, as an academic, I receive funding from various blood cancer charities. And, you know, one of the critical things about receiving funding is you need to really feed back to the people who help collect that funding. And I think that's quite important. So I've spent a lot of time over the years doing lab talks and lab tours to patients and their relatives who've been involved in collecting money for the blood cancer charities. And I've also been involved with a small charity called Be Positive, which was started by a patient with ALL. I helped them to raise money and establish themselves as a registered charity. And I've done quite a bit of stuff with them. But I've also, I've just found it increasingly helpful to work with patient experts. So I'm very engaged in designing and conducting clinical trials in ALL. And for many years now, we've had patient experts as a formal part of our trials group. And I think they've played an increasingly important role. Initially, it was probably more about, you know, just helping us with patient information and consent. But increasingly, I think that we've learned that we have to try and tackle things within the trials that patients are interested in, which is not just outcomes based. So some of the issues faced by people, especially on toxicity, are questions that we specifically need to ask and answer within trials. And so to that extent, I've found myself being more involved in working on studies of quality of life. So I've done helped with some quality of life studies led by Sam Selleck's team, which came out of the European Hematology Association project to develop some patient-reported outcome measures, which are very specific to patients with blood cancers. And what we plan to do is use these patient-reported outcome measures as part of our subsequent upcoming trial, because the type of thing that Zach was talking about, when you can have drug A and drug B, and they can both be equally effective, but one of those drugs might have a certain type of toxicity or allow people to stay out of hospital, for example. And those things are really poorly captured when it comes to health technology assessment. And I think Zach put his finger on it. They're poorly captured because the data is not there. And it often, you know, I think that when I've been involved with groups like NICE, I think patients' individual stories are very powerful because we're humans and narrative is a massively important aspect of how we relate to each other. But bodies that are funding these things can be somewhat moved by narrative, but they're generally more moved by data. So I think it's absolutely critical to collect data on patient-reported outcome measures, and it's really critical to collect those data, if possible, within clinical trials, so that when we're evaluating a new agent, you know, that we have those data alongside it. And that's much more easily done in an academic context than it is in a pharma context, I would think. I think it can be difficult in a pharma context because they don't really know what to do, I think, in engaging with patients, whereas as an academic clinician, when you're directly engaging with patients yourself, it's much easier to know how to have those conversations and not be afraid of openly discussing issues of toxicity, which I think is possibly a little bit scary for pharma to deal with, because they'd perhaps rather not have to confront those issues. But I'd definitely like to say that working together with patient groups, we've managed to effect some important changes in the UK, including launching a successful appeal against the non-approval of an agent that we thought should be approved. And I think if we had not, as academic and medical professionals, gotten together with the patient organisations, I don't think we would have effected that change. It's probably not that straightforward to get NICE to change their mind, and I'm quite proud that we were able to do that. And without getting together with patient organisations, that would really not have been possible. And I think now patient organisations, it's easier because they're more organised. It's easier to know who to get in touch with. So it's one of the reasons for me deciding to participate today. So I do think the work is really important, and I'm very happy to support this type of work in any way I can. And that's all I have to say today.
Thank you very much, Adele. So I'm now going to hand over to Pauline from the SMC, who's going to share a Scottish perspective on involving patients in their processes.
Thank you, Zach. So yes, I'm Pauline. I'm one of the pharmacists at the Scottish Medicines Consortium, or SMC as we're known. I've been there for about 10 years, and I'm going to give you a little bit of background on SMC and describe patient involvement in our processes and its impact on decision making. Next slide, please. So SMC are part of Healthcare Improvement Scotland, and we perform once for Scotland New Medicines Health Technology Appraisal for the Scottish National Health Service. So we advise the health boards on the value for patients of newly licensed medicines. The pharmaceutical company responsible for the medicine provides a submission on health benefits and justification of price relative to current clinical practice. We have a two-stage process. The New Drugs Committee assess the clinical and economic evidence, and the SMC committee is the decision-making committee. So they take the broader perspective, including patient and societal perspective. So our SMC committee includes clinicians, public partners, senior managers, and pharmaceutical industry representatives. So we communicate our advice through detailed advice documents, or DADs as we call them, and decision explained publications. So these are all available on our website. Next slide, please. So one of the groups within SMC is the Public Involvement Network Advisory Group. So this group includes 3 patient group partners. They are nominated via the Scottish Cancer Coalition, the Health and Social Care Alliance Scotland, and Genetic Alliance Rare Disease UK. It also includes the 3 public partners who sit on the SMC committee, a member representing Scottish Health Boards, an SMC committee member who is a clinician, and SMC exec members. So this group has a collaborative approach to agenda setting and provides recommendations to the SMC executive and directly influences SMC processes and strategy. At the core of the group is the continuous development and strengthening of patient and public involvement in health technology appraisal. Next slide, please. So we have a public involvement team within SMC who actively seek out and encourage patient group participation. Patient groups who agree to participate are registered as patient group partners. In 2014, 66% of our submissions had a patient group submission, and this has increased year on year so that now almost all submissions do. For each submission, the relevant patient group partners are asked to provide a written patient group submission. The SMC public involvement team offers support to patient groups with their submissions, and patient group representatives also have a pivotal role in the patient and clinician engagement meetings, the PACE meeting that Zach mentioned, and I'll describe in more detail. So the SMC papers include the patient group submission and the PACE statement as part of the evidence considered by our decision makers. The patient group submission and PACE overview are presented at the SMC meeting, and the patient group representatives attend the meeting so that they can answer any questions. Our SMC committee meetings are open to the public to observe for transparency. Next slide, please. So the PACE meetings, these are for medicines for end of life or rare conditions such as leukemias, and these medicines are eligible for a PACE meeting if there's uncertainty in the evidence presented. So the purpose of a PACE meeting is to explore the added value, added benefit of a medicine that may not be fully captured within the conventional assessment. The first one took place in 2014, and we generally hold about 3 meetings a month now. So it's a structured discussion with clinicians and patient group representatives and use a template to agree a consensus PACE statement. The group discuss unmet needs and severity of the condition. They then focus on potential added value for the patient and or the carers. This is usually, but not limited to, impact on quality of life, including ability to work, psychological distress, ability to maintain self-care, independence, dignity, convenience of treatment, and any other potential financial impact on the patient or their family. So the PACE statement has a major influence on the SMC decision, and there's, between when we started having PACE meetings, there's been an increased acceptance rate for the medicines eligible for these meetings since the introduction of our process. Next slide, please. So many patient advocates and carers have attended the PACE meeting and have shared very powerful testimonies. So these bubbles capture a flavour of the thoughts and feelings of patients, families and carers shared at our PACE meetings. So the public involvement team supports patient group participants to participate in the PACE meeting, and we've received consistent feedback that this support has been very valuable. So next slide, please. So after the first year, we undertook an evaluation of the PACE process, and phase 1 of the evaluation was a thematic analysis of 28 PACE statements. So quality of life, life expectancy, and unmet need were key themes which emerged from the analysis of the PACE statements. Quality of life was a very strong theme and was comprised of 8 sub-themes as described in this chart. So as you can see, family care impact was one of the strongest sub-themes, and the health benefits to patients. So next slide, please. Oh, back one. So there are many factors that feed into the SMC decision-making process, including the patient group submission and the PACE output. We've recently undertaken an evaluation to understand how evidence gathered through PACE helps support SMC committee members in their decision-making for medicines for end-of-life or rare conditions. So the feedback is still to be published, but the results of the findings show that our SMC committee members considered impact on quality of life as the most important factor, followed by impact on life expectancy and addressing an unmet need. The most important sub-themes identified within quality of life were health benefits and ability to take part in normal life. So next slide. So thank you for the opportunity to share how SMC involves patients in decision making, and I'm happy to answer any questions.
Thank you very much. We're going to move over to Francesco Pignati from the EMA, and then after Francesco, we'll have a discussion amongst all of the speakers and the opportunity to ask any questions you have. So over to you, Francesco.
Thank you, Zach, for having me. I must say I really agree with some of the points the previous panelists have made, in particular Giora, about the centrality of patient perspectives in all of the decisions that lead to access. Can I have the first slide, please? And also, Zach, what you were mentioning, that we can move to a type of input from patient that is more convincing on the basis of more robust evidentiary standards to address some of the claimed, at least, deficiencies. I've been 20 years at the European Medicines Agency, and 20 years ago, we did not discuss access a lot, or at least we didn't hear a lot about it. And it's only recently that it have become such an important point. And I guess what's often emphasized correctly, I think, is that there are many organizations who have, at least on paper, different roles. Regulatory agencies like EMA are more about assessing technical requirements, claims made by the companies, and healthcare systems, payers are more about so-called societal goals, cost effectiveness, etc. And then there is patient and doctor type of decisions. Now, often these are described as incompatible and necessarily separate things. And I think over the years, we've challenged that. A system which is based on so many organizations having so many different objectives can't be a very efficient system, for once. And second, if patients are central to all of them, as we all claim that they are, then how can it be that we approach our decisions so differently? And so actually, I think with more patient involvement throughout the decisions that end up in access, by involving them the more, I think we'll realize that the centrality of patient views, as Giora was mentioning, is as important for regulators as it is for doctors, as it is for payers. And also that actually the evidence that we're looking at is not that different. It's all evidence from clinical trials or from patient preference studies, whatever. We all adopt similar scientific methods, and patients are fully comfortable with looking at data nowadays, and sort of participate in these discussions in a fully informative way. So I think there's really no excuse for continuing to think of silos around different decisions, different objectives, and actually the patient involvement should be throughout. There is one type of access that we don't talk about a lot together with the HTAs, which is access to clinical trials. Now, I'm not going to go deep into this topic because it's probably the subject of a completely different type of discussion, but I think we need to discuss that a little bit more. In Europe nowadays, you see often clinical trials are just conducted, if conducted in Europe, conducted in a few excellent centers in some countries, and that's it. Anybody else has huge difficulties to enroll in any trials. And many situations in oncology, we think trials are the best way forward to patients. So what are we doing enough? As in my view, sincerely not doing enough yet in having equal access to clinical trials across Europe. But let's develop this theme another day. Let's move on to the next slide, please. I thank also Giora for highlighting the natural evolution of patient involvement in the regulatory system in Europe. It's a story of success. It's increased over the years. Are we there yet? I don't think so. I think we can never do too much of it, at least for the time being. And we have really, as regulator, to ask ourselves, okay, when we do benefit risk assessment, what does that actually mean? We are really good at assessing what the clinical trials say in terms of the variables that have been studied and whether these are believable data or not. But what does it mean for patients? Who are we regulators to say what that means? Who is any other decision maker able to say what this means for patients? I think this is where in the past, many paternalistic decisions have been made, justified on patients are biased or doctors are under whatever time pressure so that they don't have time to discuss. All things that for me are highly irrelevant if we want to improve the system. The fact is that today, in most situations, we actually don't know very well what patients think. And there is a whole IMI project on this that is looking at systematic ways for collecting patient preferences, the trade-offs that patients make, the value that they give to the benefits and harms of drugs, which I think are critical to inform regulatory decisions, but also others' decisions. And I'm going to move to the last slide. So I think it's moving away from this regulator knows best or whatever, payers know best what's good for society. Society in many of our European countries is a society that pays a lot of attention to even minorities and patients with different values about benefit and risks should have the same right to access medicines than others, representing more of a majority, perhaps. So I think we need to move from this regulator know best, doctor know best mentality to patients know best, even in all of the decisions that we think are too complex for patients. This mentality must stop. Patients have shown not only that they are completely let's say, understanding the clinical data, but if we have any doubt about that, there are all the tools that we have in order to produce convincing opinions, unbiased opinions from patients. So that the question that for me is critical for regulators, but also other, is not so much, do we as regulators think that the benefits outweigh the risks? But the question is, are there patients out there in the right decision context who think that the benefit outweigh the risks? And that's how we should take our decision and not act as surrogate of what patients want. To make this easier for the decision maker, I think constructing an evidence-based, using evidence-based methods for collecting patient preferences will go a long way. Thank you very much.
Thank you, Francesca. I'm now going to hand over to Samantha, who's going to moderate the panel discussion with all of the speakers.
Yeah, if I can ask all the speakers to put the camera on and activate the microphone. So I think we all agree that, you all share the same opinion regarding exactly what Giora was mentioning at the beginning with his two quotes. So you all agree to say that if you are not involving patient, then you are not doing HTAs. I think that came out quite clearly from all of you. And then the second thing Giora was mentioning is that patient can be representing the voice of patients. But I think one of the first questions, and actually Giora asked that question, and I think it's quite relevant. Can Francesco and Pauline maybe explain to the audience how the patient representative involved in the processes are actually elected?
Yep. Will I go first?
Yes.
So yes, so the group that we have that feeds into the SMC executive, the PIN advisory group, so they are nominated through umbrella organisations within Scotland. So that's how they choose the patient group partners that get a bit more involved in strategy and process type things. So that's how those nominations come through. So it would be the Scottish Cancer Coalition would be the relevant group. So for the actual individual submissions, we have a big database of all the patient group partners who have previously contributed. So we would go out to them. So that's obviously been built up over the years, the hundreds of contacts. And each time a submission comes in, we have a public involvement officer who actively seeks out other patient groups that would be interested. We have quite a big network through Healthcare Improvement Scotland, through general internet searches. There was one particularly hard to reach patient group where they went to the cancer hospital and attended a clinic to find a patient support group to try and get the patient voice. Because obviously there's some groups that are very well established, well used to dealing with HTA, but then you have other groups that have maybe never had a medicine go through, and they obviously need a lot more support to get involved, to learn about what there is, and that's what, so we have the dedicated public involvement team, and I think that's part of the success, is having people whose job it is to do that, to make sure that patient voice is then able to come across, and that you can support all sorts of different patient groups. And there's been no occasion then to come to me and say, right, how do we find a patient group? We've asked clinicians with these kind of things. We do everything within our power to find people who would want to be involved.
Thanks.
Yeah, we involve patients in a variety of ways. Often this is upon consultation of our scientific committees. There are proposals which are made, and then there is some type of decision process. Since years, we have established a patient and consumer group, which has its own criteria for selecting organizations that are represented in that group. And they are often consulted when it comes to proposals for a patient representative to be in a committee, to be in an advisory group, and so on. So there is a variety of methods of consultation. Thank you.
Okay, sorry, I cannot activate my micro. There's another question which I think is quite relevant as well. How would you advise patient advocates who are on this call today to start convincing the local health authorities to actually start engaging with patients? Is there any recommendation that maybe we can use from the Scottish experience, or maybe the NICE experience?
There's a wealth of information on our website. I would recommend going to that. We have testimonies from people who have participated and things like that. So and also there'd be a lot. I think there would be a lot of useful information for people to help describe what happens in our process. Giora mentioned Karen Facey's done a lot of research, and she's certainly got very, very useful publications that I think would certainly be relevant to people to help show what a difference it makes to involve patients in decision making.
Giora, I know you pushed very hard for patient organisations to be involved in Israel. What did you do when you were doing that to convince them?
Well, I had a few meetings with people in charge of the HTA in Israel. You have to understand we have a very special system in Israel. Our HTA committee is convened once a year only. They start the discussion in September and they end by the end of December. They make their recommendations. There's of course a limited budget, and they have to decide which new treatment will be included in what we call the health basket. So there are two persons in the Ministry of Health responsible. I had few meetings with them trying to open the door. The funny thing is that the one in charge, she just did her thesis in the master where she finished her education, and the topic she did was patient engagement in HTA. So she knows, I think, even better than me what's happening at EMA and NICE and FDA, and she's very aware about it, and she's very convinced that they should involve the patient. But she's being blocked from above, and they are not letting her involve us too much. So they are doing it in a very limited way. We opened the door a little bit last year, and hopefully after this COVID will end, we'll be able to meet again and expand it and start really involving the patient. Because like you said, Zach, today the feeling I have in my country is that it's only the tick box, that they let us send letters, they let the patient send the letter, they put it all in one file, in one there. And then, you know, this HTA committee, when you look how much material they have to look once a year, examining 1,000 new applications for technologies and treatments. I don't think a human being can even read all the material that is being presented to them, not alone the patient perspective on each and one of these. So I think we still have a long way to go. And that's why I wanted to hear from Francesco how we can convince them that they have to start doing it in Israel as well. Maybe you bring it to Israel when the COVID is finished and do a meeting with you and the local FDA people, local HTA people.
Yeah, if I can add to that, I think thanks. And in any way we can help, I'm so happy that you recognize some progress that we've made, but the progress really comes from you guys and how much you have pushed us to do things, because we're not notoriously the most dynamic agency here. So the credit goes to you, but one of the things we're hoping to do is through collaborations, like we've done recently a study, a patient preference study with the Myeloma UK organization. And although this has produced not much more than a scientific publication and some talks in good conferences, I think what we want to show is that as an agency, we collaborate and are very interested in working with patient organizations to also advance the field. So please, if you have any ideas or where we could help just by being there and helping out, let us know. Thank you.
Thank you.
Anyone would like to comment?
I mean, I'd like to come back on the comment Giora was saying around the paperwork that HTA bodies are having to kind of read. I mean, I know in some of the NICE appraisals that Adele and I have been involved in, we've been sent sometimes 500 pages for a single committee meeting for a single product. There's obviously a lot of information here, and with that in mind, trying to convince, say, committee members to read another 20 or 30 pages of patient input is obviously really, really difficult. And I mean, Adele, I mean, I don't know whether you want to share experiences from some of the NICE appraisals we've been involved in as to how patient involvement worked and in some cases didn't work.
Yeah, I think that one of the, there've been 2 times when I've seen it work and not work. So there was a time when we were evaluating blinatumomab, and there was a patient who was represented there, and she gave extremely powerful evidence to the committee about her personal experience of receiving this drug compared to her personal experience of receiving chemotherapy. And my judgment of that was that probably did make the difference. I think it made a difference, because the discussions were really around, because these new drugs are quite expensive. And what I found with the HTA type of assessment is they don't tend to take into account, or they can't capture the wider benefits. So, not being in hospital is likely to be a massive benefit for the vast majority of people. But hospital days and the cost of those are very rarely costed in. And I think the patient gave such powerful testimony that I think it really did bring that issue to the fore. And then where it didn't work, the exact same patient, because she was a really great representative, was invited to a NICE meeting on a completely different drug. And I recall, I don't know if you were there at that one, Zach, they said to this lady, have you received this drug? And she said no, and that was the end of any patient involvement in that meeting, which I thought was shocking. And because that shouldn't be what a patient advocate is there for, just to recount their personal experience. As it happens, it can be very powerful, but if a person hasn't had that specific personal experience, they're put into a position where they can't really represent if all what they've been asked about is their personal experience. So I felt that was really inappropriate, and it was one of the things when we challenged NICE on the decision they made. We said that we didn't think that patients had been appropriately represented, because this lady had given up her time to attend the committee, and I felt it was awful that she was just asked one question, and because she couldn't say anything from her own experience, she wasn't really consulted any further. I thought that was inappropriate.
And just to to build on that, because so for context, we as Leukemia Care, alongside the clinical community, appealed that decision where patients hadn't been properly involved. And one of the things we did when we went along to the appeal hearing was we took 2 patients who had experience of that treatment, and also a father of someone who his daughter had treatment with that treatment previously and was actually having a stem cell transplant that week. When that was why she was able to have it, was because the previous treatment had bridged her to that transplant. So one of the problems that can be really difficult for patient organisations is at the point at which treatments are being appraised. So at the point of the original meeting, it was really hard to obviously find an ALL patient who'd had that treatment, but procedurally that, as Adele says, shouldn't have been a barrier to that being involved. I mean, I know SMC and PACE have got lots of strategies for how they cope with involving individual patients and different and patient organisations for a broader perspective. I don't know what you think about that, Pauline.
Yes, so we have a structured template to make sure each point is covered that we would want to hear about. But it's funny listening to that, because actually we wouldn't necessarily expect people to have already received the treatment, because most patients won't have received it because it's not approved yet. So it's a bit of a difficult one. So what we are more looking for is what the impact of the condition is, to understand the condition better, what the unmet need is there, like why do people want another treatment, what's missing, and then to describe it's about the potential benefits. I think very much rather than needing somebody to come and explain the actual benefits, it's more about discussing the potential benefits. And so by going through each of these, and then that statement is read out at the SMC meeting once the clinicians and the patients have got together and agreed on what the most important factors are that they want the committee to know about. So hopefully we would get the full picture then, and we wouldn't have a situation where people aren't hearing the full. So I mean, I completely appreciate that we have hundreds of pages of paperwork, and it's awful the papers, but the fact that the presentation, the PACE presentation, is read out at the meeting, so it's given about the same amount of time as the clinical presentation, the economic presentation, and you've got a PACE presentation, so you're getting that full story there. And also for the other meetings, the patient group presentations are also read out at the meeting, so and they get given the same amount of time. So hopefully that does give the committee the chance to hear the full story, that they're not having to read the hundreds of pages to get that. But yeah, I think that has been really useful. Then the PACE gives us a really nice picture of what the problems are with the disease, and then where patients see it fitting in, and the added benefit. So yeah, it's been very useful.
I mean, go on, Adele.
Just a quick comment is acute leukemia is a particularly tricky specialty to involve patients with, because patients who are in the situation of undergoing novel therapies that are being evaluated by NICE are rarely in the position of being able to physically attend, and that can be a massive issue, because certain other more chronic diseases are much easier to get patient advocates to be able to meet together and attend things in public. But acute leukemia, a lot of the treatments in hospital, people are quite unwell. And so we've got to, I think probably in a way, the lockdown is helpful for that, because people are more now used to not having physical attendees. And I feel that might be to the benefit of getting patients involved. Even when they may be hospitalized, they may be willing to, to participate through Zoom and other media.
I think that's certainly something that PACE has done well for a number of years in comparison to NICE. I mean, so I remember my first ever PACE meeting so they're held in Glasgow in Scotland, which is about 5 hours away from where Leukemia Care is based, and there were problems with the train on that particular day, so I couldn't get the train up, and I dialed in remotely, and we've done around 20 PACE meetings since then, and I've never once travelled in person because there's just simply no need to. It was able to be done remotely. Now, NICE hasn't allowed you to do that previously. They've always held the committee meetings in person at either their Manchester or London offices, and as Adele says, finding patients, particularly with acute leukemia, who were A, well enough, and B, usually within a reasonable distance of Manchester or London to be able to attend the meetings was really difficult. But since we've seen the meetings go virtual over the last few months, the patient involvement has been much easier to facilitate, and I think that's really important. The other thing I think that's really interesting about PACE is the clinical input. So the PACE meetings is patients and clinicians together in a meeting, and you talk around what the issues are that matter to patients and may not be captured in the modelling. I mean, Adele, I don't know what your thoughts are on NICE and the opportunities for clinician involvement and how that influences the decisions alongside patients.
Sorry, how do you mean exactly?
Kind of, so for the, I mean, at NICE, obviously you've attended as a clinician expert at the committee meetings, and obviously the people making the decisions are not experts in ALL, and how you think the involvement of clinicians affects that decision, either good involvement or bad involvement.
Well, it's hard to know because I've only been involved in the ones I've been involved in, and you know, I've been extremely grateful to be involved because you see quite a lot of misconceptions at times. And I think, you know, just looking at the data is often insufficient if you don't understand the disease, and sometimes it can lead to, you know, some weird decisions. So I've generally felt that when I've been there with other clinicians, that we've been able to hand over a perspective that's a little bit different from the data. And I do feel that those types of interaction are potentially quite powerful, because in the end, regulators are human beings. You know, there's no such thing as, you know, I think I do worry sometimes that we regard regulators as somehow different from us in a, you know, qualitative and quantitative way, but they are humans and they're influenced by other humans. And whether that's clinicians, patients, or whatever, I think it's really important to be there and correct any misapprehensions. I think the papers that are given out for these meetings are vast, and I tend not to read most of them because you kind of know what you're there for. But if you're only there as a panel member, you don't really understand the disease and the paper is all that you've got to go on. I think that's insufficient. And having people there who can explain even small misconceptions can make a big difference.
Can I comment?
Yeah, absolutely, of course.
Okay. Again, it's different in our countries, and it's interesting. First of all, I want to say, even though with all the trouble of not engaging the patients, I think we have one of the best basket of treatment and technology in the world, because almost every life-saving drug is included, and we have a reimbursement for all the important drugs. So that's for the benefit of our HTA committee. They have done a good job with all the limitations. But in our country, when I talk about the involvement of the clinician, so actually what they do is each group of a clinician, for example, hematology or oncology or cardiology, they have a group and they actually grade the treatment that are being submitted according to the importance that they think is the drug should be given, the new treatment, from 1 to 10, depending how many new treatment and technologies. And this grading is going presented to it's discussed within a committee of the subcommittee of the HTA, and then presented to the HTA committee. And usually the drugs that get the highest grading are those which are going to be included. So the clinician have a huge influence on the final decision of the drugs which are going to be reimbursed or approved by the HTA committee in that year. And then, of course, we as patients don't have any ability to interact with the clinician in these subcommittees, and we ask to not even be included in the HTA committee, but to be able to come and present our opinion or perspective in front of the subcommittee. It still was not approved. Hopefully, it will change in the next future. I'm sure it will change. So that's one of the way I think the importance of the clinician at least in my country, and I think also in other countries. I think the second point I wanted to raise also in follow-up to what has been said is, how do we produce the real world evidence? There are a lot of challenges for us as patient organization. I see many of my friends here come from small countries. We have Drazen here from Serbia. We have other advocates from small countries where we don't actually have patients who are taking the new treatment. Either there are no clinical trials in those countries, so there are no patients who have been able to try those new treatment which are being submitted for approval, or there are no what I call early access program of the pharma companies giving the drug on compassionate program to patients that they can use it. And that's why we as patient advocates, at least in my country, we are pushing the companies to open compassionate program for patients before it's being submitted, so at least the local clinician and we the patient, we can produce this evidence how the new drug has influenced us. And I think that's extremely important. Now, because it's a challenge, we many times do what we call collaboration. And I think Zach knows very well that every time that our health technology committee is convening, I'm sending him an email. Zach, send me all the information you have collected in Leukemia Care for your NICE committee, all the patient perspective that you have done. And he's very kindly sharing the information with me. So if I don't have information about treatment of patient in my country, at least I would use information that was collected from patients in other countries on the same treatment. I think that's extremely important for small countries like mine and others to work together, collaborate between the patient organization and produce data together.
And I think that's exactly the reason for organisations like Alan. So if anyone else does want help in a similar way, feel free to reach out to myself or some of the other organisations that are doing it in perhaps the larger countries. I mean, Pauline, what are your views on how the evidence of patient input either has or can influence decisions beyond just individual testimony?
So yes, real world evidence is something that we've been spending a lot of time looking at now, how we incorporate that, because it doesn't fit in very well to conventional clinical and economic assessment. It just doesn't. It's generally not comparative, it's a lot more qualitative. So we've been doing quite a bit of work on how we can look at that and make the real world evidence useful to ourselves, how we collect that data. So there's a programme running in Scotland, the Cancer Medicines Outcome Programme, and that was funded by the Scottish Government, a 3-year programme to investigate how we can collect real world evidence, how we can find out how these medicines are actually benefiting patients, collect data on quality of life, get kind of real outcomes. So that's been running for a few years now, and they've managed to generate some really interesting information. One of them, it was myeloma, was one of the patient groups that they were looking at, and it's been really good to see what's coming, but it's very difficult. It's not easy to get this information. The IT systems aren't there yet. It's taken a long time, so I don't think there's any immediate answers to it, but it's something we all need to be working towards and get ready in how we can adapt our processes to make it useful. But for me, it's more about moving towards the interim accepted. So the decision making, the European Medicines Agency have their conditional marketing authorization about allowing people to have access to medicines where the information is maybe not all there. Then you collect data and then it's reviewed again to see, does the medicine do what we thought it might, that kind of information. So I think it's more these adaptive processes that we're working towards, and it's how we collect that information. But yeah, that's certainly for me, that it's a really interesting area and something we're spending a lot of time working on.
And Francesca, how much does the information gathered around quality of life as part of trials influence your decisions, and how much is it just about survival?
Good point. I think if you read our guidelines and if you listen to principles being enunciated, you would see that quality of life is one of the endpoints that are highest in the hierarchy of endpoints that is commonly held, like survival, perhaps even, or certainly stronger than PFS. But in reality, there is still a big gap in terms of quality of the quality of life studies submitted. And so they are often considered less credible just due to methodological pitfalls. This is changing, however, as the studies are becoming, let's say, more precise, and we are becoming more relaxed about certain uncertainties, understanding that some missing data is not necessarily that this trial is completely flawed. So they are part of the decisions. Now, can I quote to you some products that have been approved on the basis of quality of life and where, I don't know, that really made the difference? No, perhaps thinking hard, I could come up with one or two, but that's it. So it's still not the prevalent endpoint, just because also when quality of life improves, normally many other things improve as well. So people feel more comfortable in discussing those other endpoints. There is one thing that quality of life does not capture, and this is where the type of evidence that you were discussing before, like focus group with patients and clinicians or patient preference studies and so on, which is trade-offs. So how much toxicity or whatever patients or quality of life patients are willing to trade off for a gain in something else that they consider important. And this is the type of data that is particularly important for us, but I think also for other decision maker, where in the past we have lagged behind really in terms of evidence. Now, I'm not advocating that there should be a patient preference study for every single patient population and whatever decision we make. But even when we go to our panels of experts, and we typically have these advisory groups, I don't know, 10 doctors, 5 patients, maybe, I don't know, a nurse. And we ask them, you know, what do you think are the benefits outweighing the risks? They say yes or no, and then we convey this to our committee. That's not very persuasive. Even in those groups, you can do much better in terms of quantifying the value judgments. So you could say that, you know, the weight that the majority of the room is giving to, I don't know, a side effect goes between 10% and 40%, and they will justify why. The same for survival and other attributes. And then you can really present the committee with even sensitivity analysis of, look, even if you gave double the weight to this type of side effect, it still wouldn't matter. Most of the patients would still take this drug. So we need to be more sophisticated in capturing the complexity of those views in such a way that is more, how should I say, communicable and more robust, more transparent. Thank you.
Thank you. And I know lots of patient organisations are really working on this, and this is not something that's been solved. I mean, even where you can generate the evidence, how you then use it for decision making is a particular challenge. Giora, I know you've done some work with haematologists in Israel in the CML space to try and gather evidence about quality of life and side effects and what's important between the different TKIs. Maybe you could share a little bit about that.
Yes, it was a project that we did last year with one of the biggest centers in Israel called Rabin Hospital in the city in Petah Tikva near Tel Aviv. We felt that there is not enough data about the quality of life of CML patients according to the treatment they are taking. And because there were never comparison in the different clinical trials, and also the clinical trials that were used to get the approval of the TKI were done 10 years ago, most of them even 20 years ago. My TKI, the one I started 20 years ago. So there was, at that time, there was almost no data collection on quality of life. And since we have quite many patients in our group, a few hundred patients, we hear the different complaints about CML is now looked at as a done deal disease. Give a pill to a patient and he can live the rest of his life, maybe even stop treatment like I did 6 years ago. And the doctors don't take it too seriously, but still we see many patients complain about the quality of life and the lack of ability to lead a normal life with taking the daily drug. So we wanted to see, and we did a study which had about 200 patients taking different TKIs. And yeah, and we did see that, found out, at least in our study, that the quality of life of patients taking the first generation, the drugs that came out first 20 years ago, imatinib, the patient quality of life was better than the patients taking second generation and third generation TKIs later. We did use the standard CML24, which is now usually used in the quality of life trials, measuring the quality of life in clinical trials. And also we added some other questions that we felt were missing from the CML24. So also important to talk about collaboration of patient doctors. My colleague here, Felice, who is on the call, and myself were part of the team, including the doctors and the EORTC people that developed this CML24, which is also extremely important. When you develop a scale to measure quality of life, you should also include patient representative who have the experience. So I think that was done 5 years ago, 6 years ago, and I think that's also important. So I think this can be used for patients when they go to the doctor to discuss what their options. There are now 5 TKIs available in most of the countries in Israel and Western Europe. And when they go to talk to the doctors, I think they can use this data to discuss what will be the quality of life when they take the drug, because it's a drug you usually take for life.
I think that's really important, particularly as you say, Giora, around having patients involved in the development of the patient-reported outcome measures, because they're really used in a lot of clinical trials to gather the data that's going to be used for decision-making around quality of life. Esther, who obviously spoke earlier for our AML update, was involved in EHA's scientific working group on quality of life, and they've developed a new tool for hematology called HM Pro. And I know that some of the members of the Allen network, such as Anita Waldman, who's been active in this area for many years, were involved in the development of that tool. We used that as Allen as part of our quality of life survey to be able to measure what quality of life was like in acute leukemia patients, and how the different demographics and different experiences of treatment, etc., have influenced quality of life. And we've obviously presented some of that data already, but there's a lot more of that data to be presented over the next few months, because quality of life in acute leukemia is a topic that's very hard to measure, but also not often talked about enough. And with all the new treatments coming through that we've heard about from Esther and Adele earlier, there's going to be lots of difficulties being able to understand and differentiate between all the different options, particularly around quality of life with limited information there. I mean, Adele, I don't know how you would comment as a clinician around being able to interpret different treatment decisions around purely from a quality of life perspective. I know there are other factors in play, but how do you kind of understand that from the data you have from the trials?
Well, I think that one of the things that I've understood over the years is that, current treatments are, wreck people's quality of life, both in the short term and sometimes in the long term. And as a clinician, especially as you get older yourself, and you have more life experience, and you can imagine what your life might be like at certain times, you just realize that these are not good things to do to people. And it gets more and more hard to persuade yourself to tell people that they should undergo these treatments, and when you have a new treatment that is equally or more effective and less toxic, you feel a great sense of relief when discussing it with somebody. It's pretty awful to explain to somebody that this is the treatment and it's really shit, but this is all there is. And now I think we're getting into the situation where we have treatments that aren't necessarily really shit in terms of tolerance. And it is I think it's massively important to try and find evidence to support this, because in real life it's obvious, it's very obvious when I can say to somebody, right, well, you're going to have this treatment, and actually, the first thing is you don't need to be in hospital for 6 to 8 weeks, you're not going to get neutropenic, your hair's not going to fall out, all of this stuff, it just is so very obvious that this is a better thing to do, but we're not really always capturing that immediate obviousness, you know, in survival curves and things. And I think I would like to, you know, I think patient-related outcomes and things like that are absolutely critically important, because it's, to my mind, it's well worth as a society paying things that don't harm people, you know, and the harm that we do is poorly captured, you know, and the HTA type decisions don't tend to look at sort of economic harm and societal harm. They look at in a very narrow view about what harm is. And that's very difficult as well, because as a clinician looking after patients, you can see that a lot of harm is done that's not easy to capture by current measures. And it can be quite frustrating sometimes when you know that that is all that you have to offer to somebody, you know, and it's a nasty business, you know, offering to do things to people that are going to hurt them, you know, it doesn't feel great. And I think, you know, all clinicians feel that way too. So that's why it's very important, I think, to work with patient advocates and stuff, because I think we all do believe the same thing, you know, but it's just how we can make that thing something more politically important than it hitherto was. I think it is becoming more recognised as being important. So very excited. I think, you know, from the Scottish Medicines Commission, it was such a beautiful presentation to hear that they take so much care. And, you know, I think it's becoming more and more important. So I congratulate you on having this network, you know, because I think these are the ways to go in being together and trying to get it sorted out that way.
And a slightly kind of different perspective here, and I don't know whether Francesca, maybe you could kind of comment on this. We've seen decisions being made increasingly earlier with less data as we try and make sure that patients can access treatments as early as possible. How much harder is it becoming to make decisions with less data, whether that's kind of sometimes even phase 1 or frequently now phase 2 data? How much more difficult is that?
I don't think it's becoming more difficult. I think it's becoming easier in the sense that we know more and more about these drugs and the effects that they do to patients based on smaller numbers, let's say, just because we know more about the biology and so on. But in some diseases, the situation is so poor that even observing, you know, in patients who have no good other alternatives, observing some symptom improvement, some credible responses, what more do you need, really? You understand this does some good, at least to some patients. Who are we to say, no, this is not enough or whatever? This is really not our decision to make. So we are seriously criticized for this attitude, which is considered to be, I don't know, superficial maybe of the needs of society or whatever. I don't understand this criticism at all. I think others need to make decisions of whether what has been demonstrated is something they are ready to pay for, but that has nothing to do with the regulatory decision. And as long as we identify patients who would think that those benefits outweigh the risks, who are we to say that whatever, a deep response, durable, I don't know, 6 months, when there is nothing seriously active out there, that's not good enough. So it's becoming more difficult because of the criticism, but I think we still keep going down that route. And the criticism has to be addressed elsewhere. Other decision makers have to take transparent considerations into account into their decision and be accountable for them. And they cannot push the ball down to the regulators saying that, you can only approve if you have survival of big jumps in quality of life. Sorry, that wouldn't be doing a good service to patients, I think.
Thank you, Francesca. And apologies, this is probably a difficult question, Pauline. From a payer perspective or an HTA perspective, how do you kind of cope with limited or early evidence? How does that make decisions more challenging?
Yeah, so we have obviously seen that over the years. I mean, even from like our clinical checklists are designed for phase 3 studies, and we've been realising that actually we need to alter these and accept decisions are more likely now to be made on the smaller phase 2 studies. We do find it difficult when there's no comparative data, because what we want to know is this new treatment better, worse, or just the same than what our patients are receiving just now? And if it costs more, is there a benefit to justify that? So it is difficult, but we've adapted our processes. So we spent a lot of time learning about indirect comparisons, they're called. So we compare the evidence that was there already compared to the new evidence, and we try and use statistics and things to do it. So we have been adapting our processes over the years. I think decision makers do find it difficult around the SMC committee when there is uncertainty, and that's why we've been adapting our processes we've introduced the interim acceptance, which allows the decision makers to accept the medicine, but then with the reassurance of knowing that once more data is collected, that decision can be revisited. And that's when the real world evidence will really come in to show, and then the patient testimonies as to what difference this new medicine's made, and then to reassure that was the right decision to come in. But yes, it's been a challenge, but it's something that we've very much focused our efforts on and I've been working on, and I think that's where PACE is ideally placed. So when the New Drugs Committee has looked at the evidence and we've highlighted what the uncertainties are, the PACE statement comes through of what the unmet need is, how severe the condition is, and what we see the advantages are. So it very, very much flows through, and you really see the place for it. If the evidence is really clear, if everything was really straightforward, it wouldn't be needed. But as the evidence gets more and more uncertain, that's really where you see the PACE meeting coming through, the benefits.
I mean, that's really positive to hear, because I mean, one of the most infuriating experiences I've had of being involved in HTA was the one that Adele talked about earlier, where the initial decision was negative, and then we appealed the decision. Mm-hmm. We got to a final positive decision, and that treatment is now available to patients in England. But that took a year longer than it needed to. And obviously in that year, patients were unable to access the treatment. And the real reason for that was we were struggling to quantify the uncertainty from the data that was available, and there became more data as the appraisal went on, more clinical input, more patient input. And making drugs available when we know that there's benefit to doing so, we're just trying to work out how to quantify that benefit. That's a really positive shift to be seeing. And I know that's something that EMA in particular obviously have pioneered over many years, but it's a different decision when you're working out whether to pay for it rather than whether to say yes or no to that. So I can appreciate that. I mean, Adele, I don't know if you want to talk any more about that experience.
Well, I was very happy with the experience in the end, but I think one of the key things that hadn't been captured in the data, in the difference between this particular drug and chemotherapy, which was the comparator, was just the amount of time that was being spent in hospital by patients with the comparator. Because I guess the assessors round the sort of NICE panel really just saw a chemotherapy regimen as something that's administered to patients cheaply, and didn't really think that meant that somebody could be in hospital for 6 to 8 weeks, versus the comparator where almost no patients were admitted. And one of the things that we did to try and get them to think differently was collect some evidence from a couple of hospitals who'd been involved in giving this treatment on a compassionate basis. And we collected length of stay data, and we collected other things which were of relevance, such as blood product usage and antibiotic usage and that sort of thing. And although we didn't have a huge amount of data, I think it was sufficiently obvious that the majority of people with a novel treatment were spending sort of 0 to 2 to 3 days in hospital versus up to 100 days in hospital with the comparator. And so only having a sort of 40 patient experience to report it still was very powerful, because there was a massively statistically significant difference between the two. And that, if you think about it, that actually adds up to a lot of money. If you think about £300-400 a night in a hospital bed. And it also adds up to a lot of harm, people being separated from families and so forth. And I know that HTA can't really take that into account, but you can weave it in when you're talking. And as human beings, I think people do respond to that. But capturing that sort of data should be mandatory and routine in all clinical trials, in my opinion, because then we wouldn't have this situation where we have to then go back and try and cobble something together.
Yeah, I think you're right. It's the D-beds, Ds, DCs can be captured quite easily in conventional assessment, but the impact is the issue. Do you know, to understand the separation from family, and
because you just need to go to the patient administration system, and there's no argument. A patient's either being fed or not, you know, so it's not even data that you can argue, and it's just not done like it should be, you know, and it makes a massive difference, and it makes a massive difference in what we spend on healthcare, and it's not necessarily, we just need to do a little bit better, I think, and patient advocacy is really important in trying to do that.
And I know, Francesca, that EMA have put out quite a lot of position statements around the need for quality of life data and for the need for that to be measured as part of clinical trials. Do you see something that's going to happen more frequently going forward?
Yes, but I don't think the push is coming from the regulators so much for this. It's more the HTA who are using these type of models and require this type of data. We are actually in discussion with the RTC to try to develop some tools which are a little bit more sensitive, again going in a slightly different direction than HTA, which like to have tools which are completely generic across diseases. So we are trying to find tools that are more and more specific for the situation and that can read the quality of life questions much more specifically for each domain. So it's kind of going in a different direction with this quality of life data. Okay.
And do you think that will be problematic, the divergence?
No, not problematic. It will add probably more questionnaires. Problematic for participants, yes, but I think it's good information. It's good to refine the tools to collect the most relevant information.
What do you think around that, Kiora?
I think that it's extremely important to have tools. I wanted, in that respect, to go back to Adele's comment before that, and I really admire, she said she's running clinical trial and she's involving the patients in her clinical trial in different aspects. From my experience, when we talk about IITs, independent investigator trials, we don't see almost any one of them involving patient in any way, in any form. On the other hand, at least from my experience in my country and also in Europe, I haven't seen, in all the CML independent trials that are being done in Europe by independent investigator, I haven't seen any involvement of patient at all, not even approach to our network to ask if we are interested to get involved in that. On the other hand, when we talk about pharma changing the quality of life, the PROs in the trial, we do see a lot of change. I see more and more companies approaching us and trying to involve us and develop tools which are suitable for the disease, for the patient, and because, like Zach, I'm involved not only in CML, but in all blood cancers. So I see it in different companies. And I think this will, at the end, this will happen. And the fact that Francesco said that HTA is looking for that and asking for that will eventually help us get there.
I was trying to find the unmute button. That was bound to happen at some point. But I think that's a really positive direction of travel and a really nice thing to end on, that there is hope for the future. I know at the moment we've talked quite a lot in this discussion about the need for more involvement, but that is the direction that we're heading in.